It's my greatest pleasure now to welcome Professor Flavia Cicuttini. Professor Flavia Cicuttini is Head of Rheumatology at Alfred Health and Professor and Head of the Musculoskeletal Unit at Monash University. She's an international authority on novel approaches to treatment and prevention of musculoskeletal disease and a Fellow of the Academy. Her research has influenced the management of a range of musculoskeletal diseases globally. She has made and continues to make important contributions to the health and quality of life for those with musculoskeletal disease as a researcher, clinician and educator. Thank you, Flavia.
Good. Thank you very much for the invitation to speak. Great, thank you. So before I start, I'd like to acknowledge the traditional owners of the lands on which we're meeting and pay my respects to elders past and present. So today what I wanted to do is discuss with you the idea of the benefits of being a clinician scientist. So I was going to try and make a case that it can benefit your clinical work because it allows you to address questions that come up in patients that you've seen, and also the idea of being able to contribute to evidence-based solutions. And also I was reflecting on this whole area, and I thought there are also personal benefits that we can get, and that is through the opportunity to develop new skills, some personal growth by being forced to extend ourselves beyond what we're comfortable with, and also the opportunity to end up with a career that has quite a lot of variety. Now, that's not to say that people who are researchers don't do a fantastic job, people who are clinicians that don't do a fantastic job, but I just wanted to discuss with you some of the options of doing a bit of both. So, as was mentioned, I'm Head of Rheumatology at the Alfred and Head of the Musculoskeletal Unit in the School of Public Health and Preventive Medicine at Monash. And Jodie and I were just saying we're back home because both of us started off at Monash. So I just did my medicine at Monash a long, long time ago, and then did clinical training. So I did specialty training, physician training, specialty training in rheumatology. Now, there is no doubt that as healthcare professionals, we are really lucky. We hear about patients that complain, but in general, everybody you see is unbelievably grateful and pleased with how we manage them. That is the overwhelming sort of response most days. And healthcare professionals are highly regarded by the community. So people occasionally complain in that. But this is a recent Roy Morgan survey, and you can see that nurses in 2021 have ranked slightly higher than doctors and pharmacists, but almost inevitably doctors are held in great esteem. All you have to do is see what happens if any government tries to touch surgery. All hell breaks loose. You know, there may not be, some of the stuff that happens may not be the best thing since sliced bread, but no government is game because basically the community like doctors. And so they should, because the Australian healthcare system is totally fantastic, despite all the problems that we might be having. And there's a good reason people respect the health profession. Now, so as I've tried to make a plug, clinical work is very rewarding. Every patient is different, so I've put on a whole lot of hands. They're all different. Often you have to be able to sort of try and unravel what's going on. It's almost like a detective sort of activity. But clinical, there is a massive, massive, massive amount of clinical work out there. So that once you get into clinical practice, most people are almost overwhelmed by the amount of work that's out there. And so there's no doubt about it that it does tend to be fairly repetitive, and you've got time constraints because you've just got to get through the work. The other thing is that there are big gaps in our knowledge of how to treat a lot of conditions. So we can send people up to Mars, we can send them to the end of the universe, we still can't treat back pain. And so I think that there's a lot of things that sort of don't that are a problem. So we want to be able to do evidence-based practice, but there's still big gaps. So, for example, chronic low back pain is the #1 cause of disability worldwide. And because it's so hard to treat and so messy, it ends up that often the simplest thing is to give someone a pill. And in fact, we hear about prescription opioid epidemic. And in fact, musculoskeletal disease, and particularly back pain, is probably the biggest contributor. So, and part of it is that back pain is so complicated. There's this psychosocial model of structural changes and all this sort of stuff that just needs a lot of time, a lot of effort. It's very complicated. And so we revert to a tablet and off we go again. Now, I wanted to start to tell you a little bit about myself. So, one of the places that we all stopped at today was WeHi, Warden Eliza Hall. That's where I started my career. So I did a benchtop PhD, which was looking at the health of cord blood cells. Now, again, showing my age, this was at a time where you could walk into the Royal Women's Hospital and get huge amounts of cord blood and do all sorts of experiments on them, which you can't do anymore because it's all collected for transplantation and other things. Now, I thought it was the best. I had the most fun. It was the best thing that I'd ever done. But I decided that I wanted to get into more clinically based research. And so, having developed skills, in my postdoc, I went to London and did a master's in epidemiology at the London School of Hygiene and Tropical Medicine. Now, epidemiology is now the total flavour of the month. When I did it, no one had really even heard about it. You couldn't even virtually do it in Melbourne. And so NHMRC and funding bodies would pay a huge amount of money so you could do a course somewhere else, which just wouldn't happen these days. And at the same time, I also did a study of osteoarthritis, which was a twin study looking at risk factors for osteoarthritis. Now, I've reflected on what was good about that. Well, first of all, it's not just about going overseas. You could go overseas, you could go, the next state. The fact that you have in your career the opportunity to take time away from what you do every day, all your usual commitments, work-related, etc., is quite good in that you get time to sort of think. You get time to look at issues from a different perspective. And so there is this idea, like that cartoon there, where people are so busy rushing and doing more and more and more and more of the same that you can't actually take time to see whether can we do things in a different way. So, and of course, when you go away, you meet other people, you get the opportunity to work with other people and so on. Now, also, most people like travelling. Not that people can remember what travelling is, but, in the past we used to travel and etc. But you can, like working in different places, meeting different people, in your spare time, doing a bit of travel. And again, I've presented it as overseas, but, if you can't get overseas and you go to Adelaide or Sydney or Perth or whatever, it's just being displaced and doing something different. Now, when I came back to Melbourne, in those days, if you'd done epidemiology, you could virtually walk into any job you wanted in a lot of universities because they just desperately needed people to teach medical students and so on. So I was able to come back to a new job, and I was able to do clinical, combine a job with clinical research and teaching. Now, the area that I had worked on when I was in London was osteoarthritis. So I'll tell you about osteoarthritis. Most people think it's a completely boring disease, except all the people that have it. And that is that it's, it affects 1 in 11 Australians. It's progressive joint damage. People say, oh, it's wear and tear and it's, it's not very exciting and so on. But there aren't good treatments. So in Australia, we're spending $2 billion a year. There's massive increase in need. You know, in the States, it's 10 to 15 times as much. And joint replacement is what is used, and joint replacement is the poster child for waiting lists for surgery. So at the moment, where everybody's saying, oh my goodness, waiting lists have increased, they'll drag out someone with knee or hip osteoarthritis as the person that's an example, almost 90% of the time. So when I was working in London, and it wasn't just me, the way we assessed the health of joints was with x-rays, and we still examine the health of joints with x-rays. So, but you look, that's a joint. It looks pretty complex. You look at an x-ray, it's pretty simple. And all an x-ray will do is show you bone. Now, so if you're trying to assess, is a drug working or not working or so, you've got Buckley's if the best you can do is an x-ray, which is fine. That's why I think we've been very behind in understanding osteoarthritis, because in fact MRI, which is on the other side, you can see much better way of looking at the joint. When I came back from England, it was long ago enough that really MRIs were used, but not like they're used today on everything and everything that stays still long enough. They were almost only used for brains because it was such a new and quite an exciting, and the brain was where, you know, the real need was. But there was at the Alfred, there was a radiologist running the MRI machine, running MRI at the Alfred, and you know, we just had a chat and said, look, can we do better than x-ray? Now, the trouble is, if you walk in and say, oh, isn't this a pretty picture? It's fine, but you've got to be able to show that you know, if you're going to measure cartilage like you do from the MRI, it actually means something. And so I'm not going to tell you about all the validation studies, but basically we were able to take specimens, that's an above-knee amputation, put them through the MRI machine, work out what the volume of cartilage is, validate it against anatomical dissection and volume displacement, show that we're measuring what we think we're measuring. We've done lots of studies showing that it shows you loss of cartilage predicts joint replacements, increasing pain, etc., etc. Which means that you can develop a continuum. So rather than just using an x-ray, you can sort of measure structures within a joint across the continuum of the disease. That really set up the opportunity to test all sorts of treatments. So biomechanical supports. You know, there's a lot of interest in testing old drugs for a new indication. So rather than turning up with another $20,000 to $30,000 a year or $250,000 a year drug, you can take drugs like, you know, diabetic drugs like metformin or zoledronic acid that we use for osteoporosis and see might they slow progression of osteoarthritis. Can statins produce? So you can do a lot of interesting studies. Platelet-rich plasma is used everywhere in terms of in osteoarthritis. For privately funded people, it doesn't work. And of course, stem cells are quite exciting, you know. And it's interesting because everybody says stem cells, but interesting, most of the stem cells around are total nonsense. But also understanding what you're trying to get stem cells to do is really interesting because we think, oh, they're going to recreate the whole joint. But in fact, the mesenchymal stem cells that are currently being used that look as if some of them might be effective actually are a form of anti-inflammatory because you put them into the joint and they change and have an anti-inflammatory effect. They don't reconstitute cartilage. But this just gives you an idea that once you've got a better way of doing things, you can start. And in fact, what's really interesting in osteoarthritis is that in medical school say it's wear and tear and people think, oh, osteoarthritis. The trouble is it's a really heterogeneous disease, completely different patient types, and so in fact fact, our really clever ways of looking at the joint have actually pushed us back, right back, because in fact what we thought we knew was all wrong. And so interestingly, the pharmaceutical company went in with gay abandon, because if you were a pharmaceutical executive, you had one disease you were going to find a treatment for, it would be this. You'd basically could retire for the next 10 years. It's probably the biggest disease with no treatments. But all the companies scurried away because the disease just got so complicated, and they're only just starting to come back. So the other thing is, everybody says, oh, it's so bad to exercise, it's terrible, you know, jogging's bad, etc., etc. By being able to look at the actual cartilage, we found out some very interesting things. Kids that are exercise have much healthier joints than kids who sit in front of the television. If someone loses their can't walk, you lose massive amounts of your knee cartilage really quickly, and it stabilises, because you need loading for healthy joint. And exercise is actually good, unless you have injuries. So if you've got any abnormalities in the knee, then exercising on a damaged joint, i.e. AFL footballers, doesn't end well. The other thing that you can be working in your own little area, and obesity is the big area that affects a lot of diseases: cardiovascular, diabetes, cancer risk, dementia, arthritis, and so on. And so we send a lot of our patients to lose weight for osteoarthritis, because that's a big risk factor. And I got a bit perplexed, because so first of all, it's hard to see a dietitian, but if our patients did see a dietitian, almost every single person ever is advised to eat breakfast. And so you chat to your people, and they'd say, oh, you know, I'm eating breakfast, and they don't want to eat breakfast, and they're shoveling it in. And it seemed insane that we're asking people to eat breakfast when they're not hungry, when we're trying to get people to lose weight. So we did a systematic review and a meta-analysis. So I'm just pointing out that you can look at questions that are a little bit out of your usual field. And so we looked to see whether eating breakfast was a good idea if you're trying to lose weight. I'm not saying that diabetic patients shouldn't eat breakfast. I'm not saying kids shouldn't be sent to school eating breakfast. But normal adults sitting around minding their own business, do you need to eat breakfast? The answer is no, because if you put people to eat breakfast, all you do is increase the calories. And what's fascinating is people seem to divide into people who cannot live without eating breakfast first thing in the morning, or the people that just do not want to eat breakfast. And guess what? It doesn't matter what you do, just go with the flow. The other thing is that I'm mentioning when we went and saw the eye people, all of us, we're almost forced to work in silos. So I work in arthritis, great. And so then other people work in diabetes, and other people work in cardiovascular disease, and other people work in dementia. But what's really fascinating, as I mentioned, is Mrs. Smith comes to us and is in a trial of osteoarthritis. She goes to the endocrine people because she's got diabetes. She goes to the cardiovascular people because she's got heart disease. Guess what? It's the same person. And we're not good at trying to break the silos. And so, for example, a third of the community self-report having sore joints. That was the National Health Survey data for Australia. That group is enriched for cardiovascular risk factors. Again, we've known for a long time. We get told people with arthritis, it doesn't cause death. We're not going to fuss about them. They just get sore joints. In fact, people with osteoarthritis die twice the rate of cardiovascular disease, both due to obesity and other risk factors. So what's fascinating, we have just had a massive health campaign funded by Medicare, the Heart Foundation, to get everybody to have a heart health check. Okay, so it's funded by Medicare. Everybody's doing these heart health checks. It's turned out that less than 18% of people that go to a GP have had their heart health check. So if you were going to fix cardiovascular disease, you could probably get rid of the bulk of it by treating hypertension and blood pressure. Okay, much more than the really fancy stuff done at the Alfred with cardiac MRIs and everything else. It's untreated blood pressure and cholesterol in the community. And so the question is, should we be starting to think about healthy joints, healthy hearts? So people of low SCS who may not like to go to the doctor, etc., turn up with pain and immediate problem, we should be trying to deal with their pain, but also try and test their cardiovascular risk factors, do it opportunistically. So I've just gone through the first bit about the idea that your clinical work can be informed by the patients, you can add to the evidence base, etc. But I wanted to also just have a quick last few minutes about things that it can do for you. So it can have some personal benefits. So we train in a certain specialty and we're off doing, all our clinical work, but you can actually have the opportunity to expand your skill set, whether it's laboratory work, health economics, sort of data analysis, genetics and personalised medicine is now really popular. And so, you get to do those. There's a whole lot of areas. Jodie will present to you later all the work that they've done. There's all sorts of ways that you can sort of get involved in different areas, but also the opportunity to learn how to present, to publish, and so on. They're just extra skills that you have to do if you're going to do research, but they probably do make a difference to how we end up living the rest of our lives. Because in clinical work, as I said to you, people say thank you, thank you, thank you most of the time. In research, it's exactly the opposite. You've got to, Ingrid and Jodie are laughing. It's absolutely, it's a little bit like, the history's told by the victors. We all stand here and say, oh, I did this and, but, it's as hard as anything. The number of times we write a grant and, you put your heart and soul into it, it's like a piece of art and it gets knocked again and again and again. So, you really have to develop a real resilience and also the opportunity for teamwork, to work with people and value other people's, what they can do. I think it makes you a bit brave because to keep going and, does take a bit of courage and to pick yourself up, and you've got to have a really thick skin because, at the end of the day, the people who take it personally that, someone else has knocked back your work again and again and again and again, you sort of, it's only people with pretty thick skin survive. Now, some of those same qualities, if you can, consolidate them, also help us in our daily life. All of us, we're here presenting to you about clinician-scientists, but we've got families and people that are sick and people that are happy and people that are not happy. Life is always a challenge, how you live your own life, what you're able to, whether you're happy, whether you're enjoying it, your work, your family, your friends. So, it is worth thinking about whether some of these skills can also be translated to try and make, cope with the rest of your life. So clinical work is fantastic. You're helping people every day and you get lots and lots of positive feedback. Doctors are held in high regard, or any health professional is. Being a clinician scientist helps you add in a different way. There's the opportunity to add to evidence, maybe identify new solutions, and also has the potential to have personal benefits. And I've put in a final thought. So however you plan your career, I think you need to make sure that you're able to look back at your life and career with satisfaction and pride, and basically say that you did the best you could and with integrity, and there's not that much you would have changed. Now that's a tall order. And I've actually I've added that because, of course, some of us here are getting a bit older and, we're sort of been there, done that, and you think, oh, well, what's it all about? Thank you.
Thank you so much, Flavia, for that wonderful talk and so full of passion and on the topic. We'll open the floor to any questions from the room if there's anyone. Otherwise, I'll kick off. Flavia, I've got a couple of questions if you'll indulge me for a second. The first one is you were really mentioning, a lot of speakers have been mentioning on silos, and we're fixing in these silos. Why do you think that we are fixated? Is it because there's a reluctance of clinicians or clinician scientists from reaching out to each other? Is it systemic, and how can we change that in the future?
So a lot is not, it's got nothing to do with what people want to do. It's a little bit what we're forced to do, and simply the way funding structures and things go. And I think what's now happening is that sort of, for example, for some of the big funding bodies like National Health and Medical Research Council, it's been fairly siloed. I think there's more and more push to try and have translation included, and also perhaps under the Medical Research Future Fund, which has its problems, but the idea is to get more applied sort of work. So I think it's not that people don't want to work with other people, it's more just how we deal with it. And even within hospitals, for example, at the Alfred, it's the rheumatology unit has to try and survive, and, and orthopaedics has its challenges, and physio. So a lot ends up not about individuals, but just the structures we're forced into. And I don't have all the solutions, but I think it's just that's what happens.
Definitely. Anything on the table? I know there's a couple online. Anything there? I have a question and the follow-on. It's a little bit different. So you're talking about sort of the combination between cardiovascular risk factors and musculoskeletal back pain. With lower back pain being such a complex multimodal, a lot of causation, and a lot of it, let's say, linked in with socioeconomic status and risk factors, but preventive health is so underfunded. How would we tackle that problem, especially for musculoskeletal diseases?
Well, I think so for example, chronic low back pain, if you take that, has acute causes where someone will get back pain and then some, sort of depression and anxiety, and some of the people that get the same. So I think there are a few, if you forgot about any of us in the room and we reflected on a couple of big ticket items that if we could help would make a big difference to people's health. One is managing weight and obesity, and that doesn't just apply to us, rheumatology applies to lots of other areas. The other thing is mental health. Now, I think there's a lot of mental health that presents not with, oh, I feel down, doctor, but with pain. And because like if we did a survey in here, most of you have had some back pain. And so I think that's where it becomes really complex. And one thing that my heart sinks is the idea that the response to, for example, mental health is that yet again we need more psychiatrists and psychologists and mental health professionals. But in fact, one of the problems, we do need that, but there are some things that, like we tend to treat things by just giving a tablet. So if you can't sleep, someone gets a tablet. If you've got pain, you're given opioids, if you complain enough. So there is the danger that maybe there have to be community changes in the way we think if we're going to manage things like back pain, depression, all sorts of, musculoskeletal pains and so on. So I think we've got big challenges ahead.
I think there's a question over there.
Thank you so much. I just wanted to tack on to what you mentioned about obesity. Is recently there's been lots of polygenic risk score analysis with the genomics revolution around identifying causes and then treatment options for obesity, but I find that they tend to sort of center around BMI as a key metric. However, knowing we have such a diverse population and like sociocultural factors which also affect individuals' lived experience, do you think sometimes to tackle these problems we also need like new metrics for analysis?
So we do need new metrics because, of course, in an Asian population or Caucasian population or an Indian population, BMIs that are associated with disease are different. Australian Aboriginal people need to be quite thin. I would have diabetes. You know, my weight would be considered overweight in terms of metabolic risk. I think obesity, is a complete disaster, and the reason I think it's a disaster is that in Australia and most countries we gain 0.5 to 1 kilo a year. Okay, so from about the age of 18 till 30 or so, we gain 0.5 kilo a year. Okay, we do nothing about letting people know that's what's happening. We wait till people have gained 5 kilos and 10 kilos. Then we try and get them to lose weight, and the community are not aware that most of us just slowly gain a tiny bit, and maintaining weight is actually easy. It's from a it's much easier than gaining 5 kilos and trying to lose it. So I think the problem with obesity. So we've just done a systematic review meta-analysis. All the guidelines say lose weight for osteoarthritis. The evidence is that once people have osteoarthritis and are overweight, you need to lose 10% of your weight to have any effect. And yet we know that slow gaining weight is associated with knee pain. So I think it's not just the metrics. I think it's almost like an industry. And so, our response is let's wait till everybody gains enough weight and let's complain because we don't have enough bariatric surgery. But in fact, we should be trying to educate people to watch how much. And there's clinical meta-analysis showing that very low intensity interventions will stop people gaining weight. You're talking about the equivalent calorie change of half an apple a fortnight or 10 minutes of walking a day. Anyway, so I think it's more than that. It's more just the way we approach it. We've medicinalised a lot of things when really we would do better to sort of go back to public. Mask wearing was one of the best things we did, yet the first thing we did was get lots of intensive care beds.
Yeah, for sure. Thank you so much, Flavia. It was wonderful. Thank you so much. Thank you. Great. Well, it's my absolute pleasure to introduce our second speaker for this session, Professor Jodie McVernon. For those of you who know, Jodie McVernon is Professor and Director of Doherty Epidemiology at the Doherty Institute. Professor McVernon is also a public health physician and epidemiologist, and over the last 2 years has made numerous media appearances, which may or may not be a familiar face to you all. She has extensive expertise in clinical vaccine trials, epidemiologic studies, and mathematical modelling of infectious diseases, again in Oxford, London, and Melbourne. For the past 15 years, she's been building